everyone. Now I want to tell about the article and title 3 and 4 part fracture have poorer function than 1 part proximal humerus fractures. Looking plates have become a commonly used fixation device in operation treatment of 3 and 4 part proximal humerus fractures. Examining function in patients treated non-operatively and operatively should help determine whether and when surgery is appropriate in these difficult to treat fractures. There are 6 tables are result of this journal. First, patient demography. Second, classification of 3 and 4 part fractures. Third, complication and select patient and surgical variable. Fourth, functional and demography outcomes.
The category is to identify the type of fractures that have poorer function than 1 part proximal humerus fractures.
The context of this article is proximal humerus fractures represent approximately 5% of all fractures and occurs in a bimodal frequency with greatest incidence in the elderly population. The study aims to compare functional scores, ROM, and radiographs in patients with 1 part proximal humerus fractures treated non-operatively to those in patients with displaced 3 and 4 part proximal humerus fractures treated with open reduction and internal fixation using locking plates identified. A wide variety of fixation devices have been developed over the past several decades to treat displaced and unstable proximal humerus fractures.
The clarity of this article is the study is well-written report.
Contribution. This case report in patients with complex fractures using looking plates promising patient with room, comparable value, subjective judgment, and relief pain for another form of fixation associated with better room compared to hemertoplasty with variable pain relief.
So, lesson that we can learn from this article is locking plates have potential to improve the treatment and outcome of some complex fracture patterns. There was no differences in ROM between 3 and 4 part proximal humerus fracture treated with locking plates and 1 part fractures treated non-operatively, but there was found differences in functional scores. Patients with lower grade fractures had better SF36 and ASES scores. Patients that treated non-operatively had no complications, while 17% patients treated with surgery developed complications. So, in conclusion, patients with 3 and 4 part fractures have higher risk of complication when treated operatively with locked plates.
Hello everyone, now I want to tell you about an article entitled Childhood Obesity as a Risk Factor for Lateral Condyle Fracture over Supracondylar Humerus Fractures. Obese children reportedly have an increased risk of sustaining musculoskeletal injuries compared with their normal weight peers. Obese children are at greater risk for sustaining fracture of the forearm, particularly from low energy mechanism. Furthermore, obesity is one of a risk factors for sustaining an extremity fracture requiring surgery. Journalists retrospectively reviewed 902 patients, 230 with lateral condyle injuries and 762 with supracondylar fractures. Fractures type were classified by the systems proposed by Weiss et al. And Wilkins. In this chart beside me, there were 1345 patients identified and reviewed as lateral condyle and supracondylar, 302 lateral condylar fracture patients, and 1043 supracondylar patient. From 302 lateral condylar patients, 72 were excluded due to lack of BMI data, and 230 were truly lateral condylar fracture. Meanwhile, out of 1045 supracondylar fracture patients, 281 were excluded due to lack of BMI data, and 792 were truly supracondylar fracture. FXS means fracture. There are 6 tables as a result of this journal. First table is comparison of patients with lateral condyle and supracondylar fracture based on age, BMI, and BMI percentile for age. Second table is comparison of percentage of patients with lateral condyle and supracondylar when BMI percentiles are subdivided into normal, overweight, and obese groups. Third table is BMI and BMI percentile for age for lateral condyle subtypes. Fourth table is comparison of percentage of patients with lateral condyle fractures when BMI percentiles are subdivided into normal, overweight, and obese groups. Fifth table is distribution of supracondylar fractures by BMI and BMI for age percentile. And the last table is comparison of percentage of patients with supracondylar fracture when BMI for age percentiles are subdivided into normal, overweight, and obese groups. The category of this article is identify consequences of obese children sustaining lateral condyle fracture.
The context is children with obesity have a greater risk for sustaining fractures of the forearm. This study aims to identify a risk factor of childhood obesity for lateral condyle fractures over supracondylar humerus fractures. The LC group had both a higher mean BMI and BMI for age percentile than the SC group, as well as had more obese patients, 37% versus 19%. Within the LC group, children with type 3 fractures had a higher BMI than those with type 1 fractures, 19 versus 17. There was a higher percentage of obese patients with type 3 LC fractures compared with type 1 and type 2 fractures, 44% versus 27% and 26%. Among patients with SC fractures, there was no difference among the BMI for age percentiles, or percentage of obese children when analyzed by fracture subtype. Obesity places a child at greater risk for sustaining a LC fractures, and when these fractures occur, there are often more severe injuries compared with those non-obese children.
Clarity. The study is well-written report.
The contribution of this article is, it is important for parents to always maintain, supervise, and contribute to maintaining a child's ideal weight from an early age, to reduce the risk of obesity in adulthood, which can cause fractures in the lateral part of the epicondyle. Before the fracture occurs, parents are advised to give some physical activity to the child related to maintaining the child's balance and the child's strength in holding his body weight.
From this article, lesson that we can learn is children who are overweight may fall with more force. So, increased body fat has a negative effect on attaining peak bone mass and bone mineral content. Obese children had a greater number of lateral condyle fractures over supracondylar fractures because, first, varus force during a fall onto an extended elbow with the forearm supinate and pull the extensor tendons and lateral collateral ligament result in avulsion of the lateral condyle. Second, it is because the result of a upward and outward force transmit along the radius to the capitulum. The third, it is because difficulties with mobility and balance.
And then the third article title is Risk Factors Associated with the Occurrence of Proximal Humerus Fractures in Patients with Rheumatoid Arthritis, a Custom Strategy with Preventing Proximal Humerus Fractures. The abstract is, to our knowledge, no prior report focused on the risk factors for proximal humerus fractures in patients with rheumatoid arthritis. The purpose of this study was to evaluate the association between potential risk factors and the occurrence of proximal humerus fracture in patients with rheumatoid arthritis. A total of 11,907 patients with rheumatoid arthritis were enrolled in our observational cohort rheumatoid arthritis study between 2000 and 2012. Self-reported proximal humerus fractures were verified using the patient's medical records. Cox proportional hazard models were used to analyze the independent contribution of risk factors to the occurrence of proximal humerus fractures. During follow-up, mean 5.6 years, 92 proximal humerus fractures were verified in 91 patients. Multivariate Cox regression analysis estimate that the hazard ratios of sustaining a proximal humerus fracture were 1.37 for every 10 years. Increase in age, 95% confidence interval, 1.10 until 1.70. 1.95 for increases in serum C-reactive protein levels, 2.13 for a history of fractures, 1.7 for the daily prednisolone dose, and 1.97 for oral bisphosphonate use. Very control of rheumatoid arthritis with a smaller daily prednisolone dose in elderly patients with a history of fractures may be important for preventing proximal humerus fractures. So, in this article, they gave us 3 tables, consist of Table 1, demographic variables, clinical variables, and medication used in Japanese patients with rheumatoid arthritis without or with proximal humerus fractures at the time of admissions to the Institute of Rheumatology Rheumatoid Arthritis cohort. And the Table 2 consists of hazard ratios for the occurrence of proximal humerus fractures in Japanese patients with RA using unvariate analysis. And then the Table 3 consists of hazard ratio with the occurrence of proximal humerus fractures in Japanese patients with RA using multivariate analysis.
The category of this article is the study evaluate a custom strategy for preventing proximal humerus fractures in rheumatoid arthritis patients.
The context of this article is rheumatoid arthritis is well-known risk factor for major osteoporotic fractures. The purpose of this study was to evaluate the association between potential risk factors and the occurrence of proximal humerus fractures in patients with rheumatoid arthritis. A total of 11,907 patients with rheumatoid arthritis were enrolled in our observational cohort rheumatoid arthritis study between 2000 and 2012. Self-reported proximal humerus fractures were verified using the patient medical record.
The clarity, the study is well-written report.
Contribution. Cox's proportional hazard model was used to analyze the independent contribution of risk factors to the occurrence of proximal humeral fractures. Methods that can be done include controlling AR better with a smaller daily dose of prednisolone and preventing falls in elderly patients at risk of fractures to prevent fractures of the proximal humerus.
Lesson that we can learn from this article is proximal humerus fractures are likely to occur in elderly patients with history of prior fracture, high serum CRP levels, and high dose oral prednisolone. The risk factors for fractures differ according to the anatomical site. Preventing proximal humerus fractures in patients with rheumatoid arthritis could consist of fall prevention and good control of rheumatoid arthritis.